Hi everyone, welcome to the third Friday Addiction Talks Case Conference. This is Tim Wiegand. We've got some really interesting cases today. We've got three cases. I think majority of the time we're going to spend on the first and the second. And if you have some questions or comments, raise your hand. We'll unmute you. Looking for some good interactive discussion today. So I'm just going to jump into the first case, and at my site we've got Dr. Bishevitz, Dr. Connor, Dr. Malko, our fellow, and Sabina and Ivy are resident and fellow as well. So the first case is an interesting case. A 31-year-old gentleman, he's a medical student, is on his surgery rotation and he collapses in the operating room. A MERT response is called as this happens. This is the Medical Emergency Response Team. It's described as he walked into the OR without a mask, holding his head, and dropped to his knees. Someone thought that maybe he had had a seizure in the emergency department, and after a brief period where he's apparently disoriented or kind of described as waking up, he's disinhibited, making bizarre, loud comments, intermittently kicking and flailing around, and singing in a rather loud voice. We don't have any medical history. Social history is he's a medical student. In the emergency department, his heart rate is markedly elevated in the 150s. His respiratory rate's in the 20s. His saturating fine, I don't have it down, but he's saturating fine. And his blood pressure's elevated, although it's documented that the vitals are taken when he's agitated and fighting. He's violent, tangential, intermittently singing. He's sweaty. He's specifically described as not having hyperreflexia clonus and not rigid, and intermittently flailing about. So I'm wondering what some thoughts are. Does anybody have any idea, thoughts, approach for this patient? Thank you. Go ahead and raise your hand.
There's actually concern that if there's actually concern that his vital signs are, like if he's tachycardic and he's violent and there's harm to himself, you could certainly give him like a benzo in the acute setting to help.
So that's a good comment, giving a benzodiazepine to kind of settle him down, get control. I think that's a great idea. That was from our pediatric fellow, Dr. Kahn. How about Rob Cannon? Do you have any thoughts about this case? A medical student walks into the OR and collapses, now is agitated and making bizarre comments, singing, disinhibited, and this has not happened before. You see Michelle Ruha is on. Is anyone from Phoenix or Michelle want to comment or have other questions or thoughts? Okay, Rob, go ahead. Your hand's up.
Yeah, I was just he looks to be like an agitated delirium type picture, whether that's post-ictal phenomenon from a seizure or GABA agonist withdrawal or some pathomimetic toxidrome would all fit that picture. So I agree that in all of those scenarios, a benzodiazepine seems appropriate initially, and try to get some control over them, and then kind of figure out what's going on from there.
Good. Yeah, agree with that. His labs start to come back, and he was given a benzodiazepine. He was given several doses of lorazepam and a dose of haloperidol after the benzodiazepines, and his labs start coming back. And these are done early in the ED course. He's got a sodium in the 130s. His potassium's a little bit low. Chloride, bicarb are normal. He doesn't have an anion gap. His glucose is normal. Transaminase is normal. His white count, I don't have it down, but was slightly elevated. His urine drug screen comes back initially positive for THC and benzodiazepines, although the urine drug screen was done later in the ED course after they had given him benzodiazepines and it was confirmed to be a benzodiazepine. He didn't have any alcohol in his system. And at this point, we get some collateral information that his roommate says that he's been huffing ether. And he's been huffing a lot of ether lately. In the emergency department, his agitation kind of starts to wane with the benzodiazepines and haloperidol. And his CK, which was slightly elevated initially, that starts to rise later in that afternoon. And as he starts to improve, he's able to provide some history and does admit to ordering ether online. He actually gets it from both Amazon and, he said, eBay. He was ordering some diethyl ether from, and that he'd been binging on it more so the night prior. And he describes huffing ether. Despite this history, he has a lumbar puncture and a CT obtained because he had some persistent agitation, and at least for the first couple of hours. And I'm wondering if anybody has any comments or thoughts. Does this fit with the ether binge? Is this common? Has anyone else seen ether intoxication or abuse? What about Dan Sessions? Do you have any comments? Have you seen ether abuse or intoxication?
I was just telling my wife who's here also. You know, I had people when I was doing a mission in Puerto Rico that still reported using it. I hadn't seen any of them personally, but apparently they treated them basically like alcohol withdrawal. They gave them a GABA agonist and their symptoms improved.
Gloria Bashevitz, Dr. Bashevitz, have you seen ether huffing or ether intoxication in your work as an addiction psychiatrist?
I've never, ever seen ether huffing or ether intoxication. I've seen other forms of huffing, but never even heard of someone ordering ether. But wouldn't his, didn't you say he had a silly affect? He was singing and that kind of thing. That can be seen with ether, right?
Yeah, I think that disinhibition and dissociative kind of effects are reported from what I've reviewed in the literature. I can't say that I've actually, other than seeing this patient the next day, we didn't see him initially, I can't say that I've seen an ether intoxication before. I've talked with some individuals that have huffed it before. And interestingly, both of them, well, this one and the other one was a medical student and more curious about just drug use and intoxication. The other gentleman had taken it from a chemistry lab where he was doing some work in and brought some home to try huffing and described really kind of a noxious effect rather than any liking of it. And apparently this patient really likes to huff ether and goes on binges. So yes, I think your comments about treating like alcohol, you know, whether intoxication or withdrawal, pertinent. He certainly was agitated. We're worried about other things that, you know, more sympathomimetic or activating. So a GABA agonist was used as well as a small dose of the neuroleptic. So this patient is kept on the inpatient medicine and psychiatry unit for a couple of days, and his symptoms improve. And he's discharged to home with follow-up psychiatry and a chemical dependency evaluation. And within 1 to 2 hours, I got a call saying the patient that just left is now back in the emergency department again. And he looks just like he did when he presented initially. Apparently, he'd gone to his locker to retrieve an ID badge and was and then had taken the ID badge and gone to the surgery suites, the OR, where he was initially, and was described as confused and trying to scrub into a surgery. And his roommate was in contact with the providers again. He'd gotten a call from him, and he mentioned that he thought he may actually keep some ether in his locker at school. Does anybody have any? And his signs and symptoms look very similar to his initial presentation. Does anybody have any comments or questions, thoughts? The question from the emergency department was, is this still something from, you know, the initial episode, or do you think he could have gotten into something again? But I don't know if it's necessarily important to differentiate other than in terms of he looks like he did, activated, tachy, hypertensive, treating again with benzodiazepines, and then the neuroleptic would have been my approach as well. What about, there were some questions whether an ether intoxication could last for a couple of days, or would you have paroxysms of effect potentially? Or would it just simply be more of an on and then an off effect? In particular, if somebody's been huffing it fairly vigorously for a couple of days.
So you're assuming probably they take massive doses compared to what's given in anesthesia, maybe.
Yeah, more, or at least for more protracted periods of time. It's
yeah.
I don't have enough experience that potentially could, you know, have certainly the CNS effects and disinhibition, and then but waxing and waning. It seemed to me that this gentleman may have gotten into the ether again in his locker, more likely, because it wasn't really quite as waxing and waning overnight from the hospital side, but.
I had the opportunity to take care of him both times in the emergency department, and he was a really challenging case. One of the things that we were considering too is this, he's the right age for like new onset schizophrenia? Could this just be like substance use disorder, kind of exacerbating a new psychiatric condition? He brought about a lot of challenges in our emergency department because he's a medical student and there were medical students in the department, so we talked a lot about kind of privacy and just trying to take care of him the best that we could, but he was certainly challenging and trying to figure out how to keep the rest of the campus safe because he came in with scissors in his pocket after trying to enter the OR the second time. So this is definitely a very volatile patient, and it was concerning to us that we admitted him to the hospital, he left, and now he's right back doing the same thing. So he was tough.
And I know in the second admission that there was much more contact with the medical school, and it wasn't involved with this, but there was some between psychiatry and I think he was, you know, temporarily obviously taken out of classes and things. But I'm wondering, do you have any experience, Gloria, in working with, you know, any of the students related to substance use disorder or identified, you know, on a rotation intoxicated? What would the process be for?
I'm not sure what the process would be internally here. I know that for attendings, they would normally go through their department first, and then the medical director of the whole hospital usually gets involved. For students, though, I imagine they speak to a dean.
Yeah.
Our dean of students is faculty in the ED, and she was very helpful with trying to navigate a really sensitive situation because the patient wasn't so concerned with it at the time. Obviously, he was a little preoccupied, but his classmates were. Everyone was really concerned, well, what do we do now? Not just for him. I mean, he's a young student with hopefully a career ahead of him despite what happened.
Right.
Yeah.
Does anybody have any comments either on the ether or working with a medical student resident, a professional that, you know, is found acutely intoxicated on a rotation or at work?
I have a question. I just wonder how how was it verified that it was ether? Was it just by his own report, or did somebody find the ether capsule or whatever, or vial or whatever it comes in?
That's a good question. So it was both his roommate's report as well as the patient did admit to ether. We did send volatile screens, but the timing of them being sent wasn't from the initial urine test, both the first time and the second time, and they came back positive for acetone, but not for ether. So the timing, though, is a problem in both screens, and it's not clear that it would have been picked up when I look at the limits of detection and the timing. So we tried to confirm, but confirmed by his roommate and both the patient, both episodes. Why do you ask, or?
Oh, I was just curious because it's volatile, and how would you prove it? All you could say is it's consistent with ether intoxication.
Leslie, you've got a comment.
Yeah, thanks, Tim. I mean, I think that it's just, if this were fentanyl or any other opioid, I think we'd be more prepared to deal with it, and particularly the confidentiality, the idea that it's a medical professional, and I think the idea, something that, I've only seen in Cider House Rules, the movie, but where someone was abusing it, that it probably throws everybody off quite a bit. But I guess we would deal with it the same way. And it also brings up a point that really isn't directly related, but I just, I don't know for those of you I know are in multiple states. In Ohio, for example, the medical board will not allow any practitioner to be on MAT and practice medicine. And I know it's not directly related to ether, but it's an interesting point. And I also think that, we have to, that it's something we should deal with this patient like we would any other patient who potentially has the disease of addiction.
Yeah, thank you. Those are really good comments. And I mean, it's an interesting, there's certainly state variability in how they work with professionals that have substance use disorders and addiction. New York does allow physicians to be both on methadone and buprenorphine, but there is a lot of variability, and then also between students, residents, and somebody that fully has their license. So this was an interesting case. We've had other situations where someone's come in intoxicated and been identified as actively working or in school, but this was unique in that he came from literally the bedside in the OR and then went back to the OR as well, and there may have been some use, and so I think was more of a crisis imminently. And
was there any report? Do you know what happened as far as professionally?
I don't know the outcome, but I know that psychiatry had worked with his dean, the dean of students, and had follow-up. I don't know if there are specific repercussions or, from what I had seen, it was going to be a process of evaluation and then working with the patient. And all that, that I was privy to was related essentially as it should be to his health and getting assessment for mental health. There's the psychiatric assessment involved potential, consideration of, other comorbidities, obsessive compulsive disorder, as well as anxiety, panic, and they were, looking at some underlying mental health issues in addition to the substance use. It also turned out that in the history there's other things, so THC as well as some hallucinogens, but not acutely prior to both episodes of coming in to the emergency department. The mushrooms were, I think, in the week prior, and this is just self-report, and his roommates confirming the history. So it's mostly ether. So I have a little bit of a review of ether. I thought this was very interesting. It's not too often that you see ether. Ether was used as the first anesthetic really. I mean, aside from, I guess, alcohol use, just taking a slug of whiskey. But ether revolutionized surgery and anesthesia in the 1840s when it was used to anesthetize. But we get a lot of popular culture references to ether. The famous Hunter S. Thompson quote about the depths of the ether binge from Fear and Loathing in Las Vegas is, "We had 2 bags of grass, 75 pellets of mescaline, 5 sheets of high-powered blotter acid, and a salt shaker half full of cocaine, and a whole galaxy of multicolored uppers, downers, screamers, laughers, and also a quart of tequila and a quart of rum, a case of Budweiser, a pint of raw ether, and 2 dozen amyls. Not that we needed all that for the trip, but once you get locked into a serious drug collection, the tendency is to push it as far as you can. The only thing that really worried me was the ether. There is nothing in the world more helpless and irresponsible and depraved than a man in the depths of an ether binge." It's a very colorful description, both in the book and in the movie with Johnny Depp. If you haven't seen that, it's well worth reading and then seeing. So there's a little bit in the literature about ether abuse, addiction. There's really not that much case reports. This is from Addiction a couple of years ago. It was a case study describing a single patient reporting ether dependence, although in this they described no actual withdrawal signs or symptoms. I didn't have the full paper to pull this, but just a simple case report of ether abuse. And in a review of the misuse of anesthetic gases, it's really more of a commentary than a full review. The author describes kind of the history of ether and compared to some of the other anesthetics and things that are used for huffing, he really describes kind of pockets of use during history and geographically, Eastern Europe, Poland, South America, and then he comments that it's good at also helping his lawnmower to start when he primes it with ether. So colorful paper. Its effects are thought to be similar to alcohol, and beyond the alcohol-like effects, there's a report of NMDA receptor antagonism, so dissociative type effects, disinhibition, hallucinations, both auditory and visual with prolonged use and high doses, so similar things to what this patient was experiencing. In terms of use by medical students or professionals, it turns out that it's actually pretty common in South America and in Brazil in particular. It's in this one large review, which focused on quite a few different publications, mostly retrospective, but some prospective. Ether huffing and abuse was identified as usually the the fourth or fifth most common substance that was abused behind alcohol, tobacco, and marijuana. In inhalants, with ether being the most common, and some was reported in up to 20% of medical students. And this is just a section of a subset of the papers that were reviewed in this. And it was interesting, and there's apparently a particular product in Brazil, Lanca perfume, that is used not uncommonly, and when users report it, many of them report at least, the majority report at least using it once a month, and I guess similar to alcohol use. One of the papers described 22.6% of respondents, and this is about 80% of all the medical students in the group, which approached 600, described using ether spray, and 98% used it at least once a month. This was out of Sao Paulo Medical Sciences of Santa Casa de Sao Paulo, so medical school in Sao Paulo. And you all recall Curious George, or no Curious George, and I remember seeing this in some of the Curious George books, but there's an episode where a book where he huffs ether. And so it's after a big adventure that involved window washing with lots of other adventures. He falls from the window when he's washing it, and he finds himself recovering with a broken leg in a hospital. And he wanders and he's curious, and this is the 1950s as well. He finds a jar of ether. It smells funny. And as he's smelling it and opening it, he can't resist taking a sniff, and you can see the results of the ether huffing that Curious George has happened. His head begins to turn, then he felt like he was flying, then rings and stars dance before his eyes, and everything went dark. And at the end, a cold shower, and the nurse find him, and the man in the yellow hat nurse him back to health in short order, and the episode ends. And it's got good description of an ether huffing. And this is an embedded video. I don't think it will actually play, but it would. It's there to remind me to have you check out a Bugs Bunny video, Water, Water Everywhere, which came out about 5 years after the Curious George story, and features Bugs Bunny being chased with a mad scientist. The mad scientist is trying to get his brain to go in a robot, and he throws an axe at Bugs Bunny, and he knocks over a bottle of ether that he was apparently going to use to anesthetize Bugs Bunny. But the ether spills, and then he's got this classical music that then starts to distort, and it turns into this kind of hallucinogenic video, and it's a great cartoon showing Bugs high on ether as well. So, great popular culture and video. We've got Willie, you got a question or comment?
Curious. Hey, Tim, can you hear me?
Yep, you're good.
I was just curious, as far as his follow-up with getting him into any sort of treatment program for substance use issues. In the past here, I've only seen one that I recall, one adult patient with a clear inhalant use disorder, and we had a really hard time getting him follow-up only because most treatment programs in the area were not, it's not something they deal with any degree of regularity, and they just weren't sure what to do with it from a treatment perspective. And I was just curious what approach you guys took as far as any sort of long-term follow-up for his inhalant use disorder.
That's a good question. And you're right. I think it depends also, unfortunately, what insurance and kind of what probably what status the patient had. This is a healthcare professional student, and there's a program in town where many of them will go that works more closely with healthcare providers. I think that would have been my recommendation to send him to, but you're right. I think a lot of programs struggle with, well, what is inhalant abuse and what would we do with that? I mean, he should have a good evaluation with an addiction psychiatrist. I think the focus initially was psychiatry, and then I don't know ultimately where he went in terms of outpatient treatment, or if there were other things, and whether he went inpatient or anything. But I mean, ideally, I think he would have an addiction psychiatrist sit down with him and go through his history, try and understand other patterns of use, other substances, and then if he couldn't stop craving ether, potentially I would consider something like naltrexone, but certainly not right from the get-go. I'd try and learn more about him and just understand more about his use and history, and then getting his mental health treated. The most common huffing that we see is with dust off, with the computer
duster.
Dust off dusters. And I've had a number of cases that have been really difficult to just interrupt the kind of patterns of binging, and then getting them into a treatment provider that they're willing to actually go to and see. Often there's other substances involved, THC, but a variety of substances. I remember very vividly a former attorney who couldn't stop using dust-off or duster in combination with tramadol and amphetamines, and at the beginning of the month would get his prescriptions and kind of lock himself in his room and go through all of the tramadol, the stimulants, and quite a few bottles of the dust off until it was done, and his parents would kind of hear the commotion kind of calm down, and they would go into his room and bring him into the hospital at the end. This kind of pattern just happened over and over again. He'd been in and out of treatment, and they were kind of we're keeping him at home because we don't know what else to do, and treatment hasn't worked so far. So, but that wasn't either. But that was other huffing. So.
I wonder too. A couple months ago, we discussed a patient with abuse issues with dextromethorphan, and every once in a while we'll see a patient who does abuse a unique substance, but he was accepted into the outpatient treatment program that's associated with our academic center and went to groups and saw the psychiatry team there. And it didn't seem to have been an issue for coverage for him, but I wonder, as long as you can prove that he meets DSM criteria for addiction, that it should be able to meet treatment for an outpatient program.
Sure.
Yeah, I haven't seen this as much in the last few years, but 10 years ago, there was more, well, it wasn't on your drug screen, so you probably don't have the disorder, and we can't admit you into the program. I don't see that really happening anymore. Maybe, do you see, what I'm talking about, Gloria?
Yeah, no, I know what you're talking about, but I do think most centers around here would admit such a person. Yeah, true, you can't see anything on a drug screen, but that's more of a problem of follow-up, too. You can't verify that he's not using the ether.
Yeah. Well, good. Are there any other comments? Otherwise, we're going to get to this next case, which is, I think, quite interesting. So we'll turn it over to Jade. Go ahead.
All right. So I'm going to start with a case of a patient who's on our consult service right now. He's a 39-year-old male. He had a pretty recent history of craniopharyngioma resection and had been admitted to the hospital about a month and a half prior to us getting involved. He had baseline left-sided deficits as well as many pituitary issues status post his resection. And he had been admitted with hypernatremia, some lethargy, and was admitted to the hospital medicine service. He was on medications listed below, and kind of note, his social history is really significant for not very much. His wife made a comment that the only thing he ever smoked was the smoke when he was inside a fire for his firefighting job. We got involved, he was admitted on about 6 weeks before we got involved. He had been talking throughout his hospital stay, a little more confused than normal, but then had a pretty abrupt decline that brought him into the ICU, requiring intubation and respiratory support. He was shaking, having fevers, increased work of breathing, just all of a sudden not doing very well. And while he was being evaluated for forms of aspiration, other causes of his symptoms, he had been put on pretty high levels of sedation. He was opioid naive. Overall, the only other medication that had been started during his hospitalization before this episode was gabapentin, and he was on some pretty high doses of fentanyl. During the several weeks while he was in the ICU and maintained on a fentanyl drip, they had been having continued issues with agitation, and different combinations of sedation were trialed. Unfortunately, because of his hypothyroidism, he had been relatively bradycardic, 40s, 50s, and while he had some trials of dexmedetomidate, that wasn't really a sustained option for him. He had been on a ketamine infusion for a little while. By the time we got consulted to help with some of his sedation requirements, it had been weaned off because he had been on it for, I think, at least a week. Additionally, his QTC was fairly prolonged, especially with his bradycardia. They wanted to kind of avoid using antipsychotic regimens and neuroleptics. So we got a call when he was on fentanyl at 175 mics an hour. He was getting boluses almost every hour. And even then, he was restrained in bed, kind of thrashing around. Kind of keeping in context for him, I mean, he was a year ago a very healthy, interactive person with no neurocognitive deficits. And not only is he struggling with some ICU delirium, but he's having worsening visual impairment, kind of recognizing now that he's almost nearly blind, and kind of just trying to keep this gentleman, who's a fairly big guy, pretty calm, and it was very difficult for the ICU. So the question they had for us was, how can we treat his agitation, and what are we going to do about his sedation? Because at this point, we've only been going up on his fentanyl requirements. He's requiring more and more, and they were pretty aware that it's just kind of part of a prolonged ICU course as far as requiring more fentanyl. So could you make any recommendations for this patient about what we could try to help the ICU in taking care of him?
Or does anybody else get involved in, with their talk service and, some of these complex sedation, delirium management in the ICU? Any thoughts or comments? This is Tim again. We've had a lot of similar patients in terms of fentanyl infusions, usually not quite so long, and they're often opioid dependent before they start the fentanyl infusions, and we're consulted either pre or post to help with the opioid dependence and withdrawal, and in many of them we're able to turn off the fentanyl, ratchet up other sedatives, and sneak some buprenorphine in while they're sedated, and then the fentanyl goes away, their opioid withdrawal is an issue or dependence goes away, and often then, for many of them, the sedation wean is much easier, simplified dramatically. If anyone's interested, we had a poster and abstract at this last year's ACMT conference describing that. But this is different. He wasn't able to tolerate any of the fentanyl off without having very quick, abrupt symptoms. Even slightly down, they were take one step decrease and rebolus. Any questions or thoughts? Elena, I was just going to ask you.
In terms of folks in the ICU who have trouble coming off of their kind of iatrogenic dependence, we've seen, I haven't done it personally, but we've seen some of the intensivists here start using like low doses of methadone, starting people on somewhere between 10 and 20 milligrams a day, and then having more success weaning their sedation with just a little bit of basal opioid on board. So, something to consider.
Yeah, that's a good, I see our pediatric ICU does that. They'll often, not just a little bit, but replace most of the sedation if there's withdrawal, and then do this very slow wean. So I think replacing, if you have a short-acting sedative that someone's dependent on, replacing some of it with a longer-acting drug, so there's kind of, it's not all rapid symptom development because of the short-acting nature of it. There's some blanket of long-acting drug. That makes sense.
I think that's a good idea as far as it could work for a lot of patients. I think one of the things that might have gotten brought up for this patient is his QTC issues, and maybe starting on really high doses of methadone may not have been the safest thing for him, but I like it as a concept in general. All right. So, kind of in the same wheelhouse, we were hoping to explore the opportunity to try a microinduction on this patient. Kind of how Tim had described our typical kind of holding medications for several hours to try to sneak in a small dose, 2 milligrams, let's say, or 1, is something that this patient really wasn't going to tolerate very well. And keeping in mind, too, kind of risk for precipitated withdrawal in him. I mean, he was already so agitated and was pretty much nonverbal at the time because his delirium was so intense that I think risking something like that and not being able to communicate with him very well, we were concerned about how that was going to go. So we were brainstorming and thought, well, instead of turning the fentanyl off, we could try to just do some very small microdosing and I'll be allowed to continue his infusion while we're trying to get therapeutic levels. We've talked about this before, and I'm going to talk about a couple of papers that kind of touch on this concept, but some of the proposed algorithms include both sublingual and IV dosings of very small doses of buprenorphine, kind of in the less than 100 to low hundreds of micrograms of buprenorphine at a time. There's also some thoughts about being able to apply a Butrans patch that can kind of gradually absorb and create kind of a seamless upward titration of therapeutic medication. And like when I don't want to go into too much the pharmacokinetics of buprenorphine and kind of how the medication works, because we've talked about that a lot, but I think just something to keep in mind, if we can find a tolerable dose at a very small level and only saturate some of the receptors at a time instead of displacing them all with a large dose. I think that's the concept that these microinductions are going off of. So the table to the left, we had brought up this paper kind of in conversation. It's a paper outside of the United States, from Switzerland, Hemming et al., that described slow titration of buprenorphine sublingually while the patient is continuing to actively use heroin, and kind of estimating the amount that they're using and creating a, while going up on one, going down on the other type of schedule. And so this is coined the Bernese method, and I haven't seen a lot of applications of this yet, at least that are published in the United States, but this case report, two case reports actually, describe this method, and it was very well tolerated in the two patients that they described. Kind of going through the literature a little bit more, there's some talks about microdosing when it comes to kind of transitioning patients from full agonist therapies, whether that's really high dose, short-acting or even long-acting full agonists like OxyContin or oxycodone, as well as methadone. And so the papers that I kind of pointed out talked about like single doses that were tolerated fairly well in these patients. So we kind of, between the three, we're trying to pick a dose that we would consider starting for our patient. Does anyone have any questions about kind of this concept?
Yeah. Why is it called the Bernese method?
I'm sure there must be a name of someone within the paper. I don't think it has to do with a dog, but
isn't there a Bern, Switzerland city?
Well, that's a good comment. That could be. I don't know if it's done in Bern or not, but Bernese, yeah, it wasn't the first author or the last author. I've always wondered. It's only the one case, so.
Bern's capital of Switzerland.
Yeah. I know this too while
I've been there. It's nice.
While looking, trying to find some papers to make some decisions, there's some groups in Canada that talk a lot about methadone transitions and using these microdosing schedules. So I think that we're going to see this more and more in kind of different applications. But certainly no one really talked about it in the critical ICU patient when we're trying to wean infusions. I apologize for these for the text being so small, but I kind of wanted to illustrate a bit what our dosing schedule was like. So day one was the day we got this consult, and or the day after we got the consult, and we were talking with our pharmacy and trying to figure out what products do we have to start a very, very low dose of buprenorphine, and we only had the 2 milligram strips on formulary as well as IV formulation of the medication. We had asked our pharmacy team to kindly order some 150 microgram sublingual strips of buprenorphine mono product, and they were able to get it to us within about 48 hours. So we had said that, well, we'll start IV for now, and we had chosen to try and stick around like the 200 to 250 microgram equivalent per day and just split it up, hoping that this challenging patient might tolerate it a bit better. So we gave him a 30 microgram IV dose, which is about equivalent. We kind of went back and forth between different resources, but between 45 and 60 micrograms of sublingual or buccal administered of buprenorphine. And then pretty quickly we were able to get the 150 microgram strips in, and we're buccally giving him 75 micrograms Q6 hours while he was getting his normal fentanyl infusion. He got one bolus of fentanyl that day, and we kind of came up with a plan with the ICU team that for agitation, instead of bolusing with more fentanyl, because he's in restraints, we have to do something that we're going to try some Ativan and Benadryl, which, like you'll see through the adjunct column, he got a couple of times during this protocol.
Which he was having these paroxysms of the same degree of any agitation that needed medication administration before as during. This isn't an escalation of these episodes at all.
Yeah. So on day one, he would just sit there and moan, and that was kind of his baseline. He would moan, he would shake, he would pull at his restraints, and that was on the high dose fentanyl infusion. That's kind of where we started at. And so for the first few days, until we got to more substantial dosing, we had the team keep him on his normal fentanyl infusion. We didn't do what the Bernese method did with titrating down right off the bat, just because these doses are so small. And we went from 75 mics sublingual Q6 to 150 Q6 to almost doubling on day 3 again to 450 Q12. By that time, nursing started to report he was following commands and kind of just starting to settle out a bit. He was tolerating it just fine. There weren't any concerns for opioid withdrawal. They were kind of keeping an eye out for things as far as COWS scales. If anything, he had somewhat of an ileus the whole time, probably related to his opioids, but had no increase in his tachycardia or hypertension. His pupils, unfortunately, were unreactive, so that was a hard thing to track for him. Kind of by day 5 to 8, we were able to start weaning down his fentanyl as we began to get into more therapeutic doses of buprenorphine. And by day 8, we were on 8Q12. We discontinued the fentanyl. I walked in the room, and he talked to me like a normal person, and it was quite amazing. At first, the family was definitely on board. I think they weren't sure what to expect or what this medication could offer. But the nursing team, the ICU team, they were very, very thankful that this was a relatively easy process, and the patient did really well with it. So it was a success in our book, and it only took a week. I guess looking back, there could have been things that maybe we could have done differently as far as escalating doses, maybe slightly quicker in the beginning. But I think the patient kind of guided our therapy a bit. But he did really well.
He was getting physical therapy within 2 days out of bed, and within less than a week, mostly I think due to logistics, and that being the delay, he was moved out of the ICU and into just general medical floors and moving forward. And now we're in the process of weaning the buprenorphine a little bit, because I think he'll ultimately end up going to a rehab floor, hospital or unit, where we'll probably run into trouble with continuing buprenorphine. We seem to have that problem, but he's tolerated now. He's on now we had it actually held because he'd been a little bit sleepy these last couple of days, but he's also been really participating in a lot more physical therapy and moving. That just maybe is extra activity. So, questions, comments, thoughts? I know, Elena, you had some comments or questions yesterday. We talked about
I'd love to put to the group and get some thoughts, because since I talked to you yesterday, Tim, we've had some updates via the pharmacy. We have a gentleman who's 41 years old and has a very long-standing history of OUD, as to the point where he is using about half a gram of heroin a day, and was admitted for some flexor tenosynovitis in his right hand and underwent debridement on Tuesday, I guess it was. So still fairly close to his, his operative date. The problem is that even with the pain control he's getting right now, it's certainly not adequate, either in terms of his pain nor in terms of controlling any withdrawal symptoms. So he's simultaneously in a lot of pain from the surgery, but also having some objective signs of withdrawal. And so he really is very hesitant to try and get on Suboxone because he doesn't want to withdraw any more than he already is. And he's been loaded up with all of the adjuncts as well, so the clonidine and loperamide and dicyclamine and everything else you can think of. He's already getting rather significant doses of all of those, and his withdrawal is still not well managed. So this is someone we were hoping to do, a microdose induction on. The problem is that I talked to the pharmacy today, and the only formulations of buprenorphine products that we have are the 2 milligram and the 8 milligram sublingual tablets. They don't have films, they don't have patches, they don't have the injectable forms. So I think we may be a little stuck, unless anyone else has a brilliant idea.
Only thought that I had, because we were trying to think about, could we use our 2 milligram strips for this process? And the strips are long enough that breaking them up into tenths isn't the most unreasonable thing. It's not exact. I think with home inductions, you can kind of get away with this a little bit, because you can kind of work with the patient and cut them with them and kind of guide them through it, where the pharmacy, they get a little uncomfortable, at least here, with cutting them more than into fourths. But you could talk with your pharmacy about it and kind of explain the risks and the benefits for the patient and for the pharmacy, and see if they would be willing to kind of do a measured out cutting and see what that would look like. I guess you have the tablets, though, not the films.
Yeah.
So just thinking about that, because we have the films, and that we thought about this too. Tablets are hard to cut.
Yeah, I mean, sometimes you can order maybe the IV Buprenex, from whatever supply, and get that within a day or two, probably. That might be an option. And what I've seen in the pain literature, there's often use of Butrans adjunctively to other opioids, and it's either on a patient, and then they add full agonist, or vice versa, the full agonist there, and Butrans is transdermal buprenorphine added on top. And I've seen that done up to 20 microgram patches, and that's 20 microgram patches per hour. And it's a slow onset, so it would be, just small doses getting in gradually, and that would be really hard to parallel with a sublingual dose. But if you think of how much over a day, the 20 microgram patch per hour, that's 480, that's almost a half milligram if you just start with a 20 microgram patch, which I guess if you did a quarter of a film and the bioavailability is about 40%, you're starting at a smaller dose than the full day of the 20 microgram patch. It's different. I mean, it's concentration over time is going to be very different for the sublingual than applying the transdermal patch, but that might work especially if you've got supportive medications. Start with a quarter of a 2 milligram tablet, and if he tolerates it, space that out. I mean, otherwise, I would just load the guy up with supportive medications and hold the, what the opioids that you're using, switch from methadone to maybe a short-acting opioid, and make it an easier switch. With like hydromorphone or fentanyl, we can usually go 7-8 hours for hydromorphone, fentanyl 6 hours if it's not a continuous infusion, to getting the first dose of buprenorphine in sublingually without any problems, going like with a 1 milligram dose.
Wow.
So you can do it pretty quick.
Okay. And you were telling me yesterday that, when you're, starting after discontinuing intermittent dosing of hydromorphone or fentanyl, that you can do 1 milligram and then an hour or two later you can give them another 2 if they're still doing well. Is that what you were telling me?
Yeah, usually just escalating quickly, like going from the 1 milligram, an hour later 2 milligrams, an hour later go right up. It works quite well. It's that first dose, if it's small and it's around 1 milligram, it seems you can do it pretty close. I haven't gone closer than 6 hours, like for the fentanyl. We've done several 7, even a couple this week, waiting about 7 hours for hydromorphone, and the patients tolerated it without any symptoms. So you might even be able to go sooner.
And that might work for him because, I was looking through his MAR today, and, nursing is documenting that, his pain's still terrible because even though he's still getting dilaudid, but his last dose of hydromorphone was 5-6 hours ago, so he's probably already there. So cool, we'll give it a try. I'll let you know how it goes.
Great.
We've had a couple of patients that have had kind of extremity pain issues, and our anesthesia colleagues have often at least considered doing some regional nerve blocks to help kind of get through that really uncomfortable period. Other things like ketamine are kind of a short-term bridge, but I would probably in that patient more explore like a regional nerve block, especially if you're trying to do a transition where you're holding more than you normally would.
Yeah, that's a good idea.
And that's a great call. We actually requested that our pain service, who's involved in this fellow's care, consider something like that, and they, for some reason, did not want to pursue it. Nor did they want to increase any of the doses of his opioids. So he's kind of in a tough spot.
That's weird. Why would they not consider the nerve block or...
A regional block? I have no idea. I have no clue. So...
The only things that have been pointed out to us when we've asked for it is sometimes if they're trying to closely evaluate for compartment syndrome, and you didn't want to completely remove being able to observe for that for a few hours, but kind of explaining it's going to be a short time, we can evaluate other ways. And then there was a nerve block we wanted to do, but it was they would have to inject near the site of a pretty bad infection, and they didn't want to take that risk. But if they can do it proximal enough away from his hand, it's probably something at least worth trying to advocate for again.
Got to be some other questions or comments. We've talked about this in some of the other sessions, and there's usually some good discussion.
Philip?
Yeah. Hello?
Go ahead.
No, I was,
Hello?
Yeah. I was just going to say that we're going to publish a paper. I can't give much more on it because it's in process, but of using oral liquid buprenorphine because it has low bioavailability instead of sublingual. And so you can use an IV prep low dose. Just a comment.
That's interesting. So I guess having the patient maybe take the sublingual and swallow instead of taking it appropriately.
Right. I mean, you're using sublingual to avoid the first pass effect, but in this case, you might want to not avoid the first pass effect.
Yeah, that's a great idea. That's interesting. You make do with what you have. So.
What type of patient did you use that?
It wasn't no. I'm the editor of the journal. It was done by another clinician.
Hey, this is Elena. If you have a tablet and you have them swallow it instead of administer it sublingual, what sort of bioavailability are we looking at? I know it's low. I don't know how low.
Go ahead. You're going to. I've seen data under 5%, but a range maybe 1 to 3, up to 5 at the most.
Yeah, 1 to 5, I think is a good guess.
Okay.
And of course, if you're starting with an IV prep, you can titrate it because the patient's going to tell you how much is absorbed. But anyway,
that's good.
That's all. It's been done.
Sure. No, thank you. I mean, I don't see that this is going to be done. It's interesting because after we did this, like within 2 days, the ICU called and said, "Can you do this again to another patient?" And the response was, "Well, we can do a normal induction to this other patient. We'll just stop their hydromorphone at midnight, and we'll help you start the buprenorphine 7 hours later," and they tolerated that fine. So, I think the reason to do it is we cannot stop the full agonist or support somebody through holding them, and that's not going to come up too often. It's mostly going to come up in, I think pain patients, pain or just primary sedation rather than just the withdrawal, or, there's other things going on, but but it comes up enough. There's enough opioid cases in particular in our ICUs, so.
Even our, one of the outpatient recovery programs I work with that has they call it, it's their form of their detox. They've been struggling a lot with getting patients onto buprenorphine, with using fentanyl so frequently and not being able to kind of wait the full amount of time. And they've done some of like a modified microdosing protocol, giving them a half of a milligram and kind of starting from there and starting with really low doses the first few days. And if they use, and then kind of, it's not really regimented in a way that I would feel comfortable kind of explaining it in depth, but they've described things like that they've worked with patients on.
Tim, this is Leslie. Can you hear me?
Yes.
I had a question about what you were talking about in that paper before on the Bernese Mountain Dog. That's all I can remember. What was did they just ask for subjective withdrawal symptoms? Was that the end point? I mean, because that would be, I'm just wondering how they judge when to change the doses with these micro inductions, how often to increase the dose, and, what are the endpoints? I know it was only 2 patients, but I was just curious.
I know that they were kind of documenting the COWS score through the paper, but I'd have to read it again to answer that better.
And our patient was just looking at physiologic signs of, distress, withdrawal, different than his baseline heart rate, skin,
But again, someone in the
restlessness.
ICU, obviously, you have a lot more control. And I mean, there are people that I know that patients that don't want to start bupe because they don't want to go through withdrawal to get on bupe. So they're like, just give me methadone. And so if there was some way you could do this to solve that problem, but you don't have the luxury of having them in the ICU checking their vitals every whatever and having someone there all the time. I just don't know how, it would be a hard sell to them, because, here, take this, it would have to be in a really, I'm guessing they did it in a more controlled environment and the patient was there and wasn't at home. And I don't know. I guess I should read it myself. Right? That'd be a good idea, wouldn't it?
Although I think a lot of times people aren't set up appropriately. They're told that you need to be in full floored withdrawal and, you got to wait 36 or 48 hours and it's going to be miserable. You want you sick, and that's not really the case at all. So I try and have the patient in very mild withdrawal and then, avoiding really long-acting opioids. If they're using, heroin or fentanyl, that should be able to start pretty soon. And then the key is starting low. Some of the inductions just throw people on like an 8 milligram dose right off the bat. The smaller the dose, the better. And then, and actually, I think that what some of the programs are doing, where you say, well, maybe that's approximate to a microinduction, is actually quite inappropriate. You got to go quicker and get more in because they're not giving enough and they feel miserable, so they're going back to use instead of the actual small doses causing a problem. You just need to get more buprenorphine in. So going small and then repeating pretty quickly, like, Elena, your patient who's not going to tolerate a long time in between, if you did a small dose, then another small dose, then a really small dose, then another small dose, I think they're going to get really upset and be miserable when you go small, a little bit more, then you're on your full dose and ready to go. And I think doing this, I don't like doing a lot of home inductions for patients like this. I would have them come in and sit in front and kind of hold their hand and then giving some clonidine, but getting it all in so the day that they leave the induction, they have essentially their full dose in their system. I think that's really important. There's a lot of repercussions
so you
for
could
the
do
more
that with this. With this system, you would just be you're just talking about like baby doses, but overall it's kind of the same scale, and in the end point, they should feel the same when they leave, and maybe because that sounds like what you're talking about.
Yeah, although the microinduction leaves
like
it fully in place. Yeah, leaving the Bernese leaves you got it still going on. And it's even what we did was different than what they're reporting in the literature. The self-report of heroin use, and there's intermittent doses. This is I guess continuous
you knew
ongoing.
Exactly what he's done. Yeah.
It sounds like
really interesting.
Just pulled up the paper again. In case 1, it was a patient that kind of went through it very easily and just had some texting support of a physician to make sure that the dosing structure that they kind of brainstormed didn't need to be adjusted. The second case, it took a longer period of time, with a lot of kind of visits in the office. So again, it's not a standardized protocol. It's just kind of the case descriptions. But I think you could do a combination of the two and what works for your center and what resources you have.
I think it's just like everything in medicine. We physicians realize that everybody wants everything to be standardized, but until our patients are all the same, that's probably not going to happen. So, we have to be willing to treat them based on their symptoms and their history and everything else. And I think this is an interesting option that makes sense, and I'm glad you brought it up.
As you can imagine, if you had a 10-day structure and a patient started having some mild withdrawal symptoms on day 3, you can kind of just hold the course at that day, give them some supportive measures, and go from there.
Well, we're going to stop with the 2 cases today, and the next one we'll save until February. I think what I'd like to do in February is talk about the optimal duration and time to wait to start, buprenorphine, and mostly in emergency settings. There's been several publications. The Annals published a review of buprenorphine in the ED for opioid withdrawal. There's interest in starting it after heroin overdose, even in patients that have gotten naloxone and woken up and naloxone's wearing off. So we'll talk about the timing, and we talked a little bit about today, but timing and onset of the first dose of buprenorphine and how to do that in February. So if any questions or if anybody has any cases that they'd like to present, send it via email. That would be great. And thank you all for joining today. We will hopefully have you all come back in February. Have a good weekend.
Thanks, Tim. Have a good one.
You too. Thank you.
You're welcome.